just start by acknowledging the traditional owners of the land that we meet on today, and also love and respect and honour to our elders, past, present and future, and also just to thank our ancestors for getting us here safely. They did a couple of turns on the way through the country there. I'm Hayley Longbottom. I'm a Jurindja woman from the South Coast, and I work out Wyminga. I'm the Health and Wellbeing Manager.
I'm Kristine Falzon, so I'm also in the South Coast. I'm registered Jurindja and our Northern Lake communities, and I'm part of the executive team at Longbottom. So we've put a few notes out, so we bring up for everyone who last how many people were going to be here, and a few of our few booklets. So just trying to cover everything in this time, but just a little bit about Wyminga. So we're based on the South Coast, we're based within Nowra, and the reason we talk about Wyminga, kind of talk about the program, is because we can't do any of our programs without the model of care and how we work out Wyminga. So Women's Service, we've been around for about 30 years. There's now over 125 staff covering programs holistically. So we've got programs from social enterprise to clinical services to health and wellbeing, maternity services, across the board, which there's more information in the book.
And just before we get into it quickly, we just want to acknowledge that this is our story from our country and our communities, and we respect that everybody's stories and communities are different than ours as well. So we were an innovation site for TIS also. Our program was Balang and Binjalang, obviously pregnant woman. Balang in our language and Binjalang is pregnant woman. So all of our staff across the service, the whole of Wyminga, are actually trained to deliver smoking cessation, and we find that works really well because, as everyone says here today, it's everyone's business to support our communities in their health and their well-being. And also too, we're a wellness-focused organisation, we're not an illness-focused organisation. So our GPs, our allied health professionals, they go through a cultural induction before they are even able to see our women and their babies in our service. And that doesn't fit everybody, but that's not really our problem. Well, it's our women and our communities that, is our main focus and the way that we care for them.
And I think just a bit of time later is a part of the booklet is our model of care, and there's two models there, which is the service model of care within the healing framework, but we also have a staff wellbeing framework. And with our staff, with over 125 women, 75% of our staff are Aboriginal women, so our clinical services, when we talk about our clinicians, we're talking about Aboriginal women. So it's, cultures at the core, it's at everything we do. So in regards to the Tackle Indigenous smoking program, so it was a part of the innovation grant, unfortunately much the same as a few others unfunded now. And I think it is that, trying to evaluate a project that is bigger than itself, it's hard to measure that impact when it's a ripple effect. It's a one conversation, especially when you're working with women, other caregivers of the family too. It's a ripple effect that feeds off from that too. That's hard to measure and capture.
I think, the best part about, the way that we deliver our service is that we're professional community women. So, we live in our community, we work in our community, we're qualified in our fields, and, our women relate to us, we relate to them because we are them. And it's about, just walking their journey with them, offering, giving them more support than that 10 to 20 minute consult within a GP setting. So it's not about cultural appropriateness for us, it's about decolonising that practice for our women to feel safe and secure and to be able to share their stories, be honest, know and trust us at the same time. And then if there's referral pathways, ensuring that those referral pathways that professionals are going to are also work the way that we work as well. And I just want to touch on when our previous TIS worker moved over into another program in our villa building where, one of our, I suppose, health and wellbeing trainees, I said to her, I really need you to take up, this, TIS role. That's not a TIS role anymore. And she said to me, but I'm on my own journey with my smoking, and I said, but you're perfect because you know how difficult the journey is. You know, you can relate even better to that woman that's gone through that journey. You know how hard it is. You can do that, you know, accidental counselling, they call it, but to us it's yarning, right? And relating. And, you know what sort of NRT she needs, know how much she needs, and just keep that consistent relationship going with them. And that works really well.
So part of the program we had was about implementing one of our programs, which is Devil Gently, which I will talk to in a moment, and implementing in other areas. So we had one, like we're based in the Shoalhaven, and then north we had one based in Wollongong and Aurora area, one down the coast. So it was originally with Wundama, but then that changed to Katungal. So, and in the north it was going to be with Illawarra AMS, and then that changed to Kimdichi, so we went straight to the community. So a massive part of that work is, you know, doing the training about capacity building within that community, knowing where our footprints are, and then, you know, protocol of going into other communities. So it's really about these, our learnings, this is how we, you know, implement our model, but how do we do it so we can work within the community. Our team really fitted within our, we had regional manager, regional coordinator, and then project staff at each site.
And I think too, you know, it's all about that self-determination, that empowerment stuff. So through the Deadle Deadly program, you know, it was about a woman coming in, and a part of the Deadle Deadly program is, you know, physical activity, nutrition, smoking cessation, and chronic illness prevention and management. So it was tailored to the need of the woman, and you know, she would come in and she'd do her pre-assessments and begin her journey, you know, through a healthy lifestyle. And it was, you know, we found that once she exercised and, you know, implemented some of the new things into her diet that she probably wouldn't normally, she would say, oh, you know, I need to quit smoking. I know it doesn't, you know, fit with me, but I'm finding it hard. So, you know, then supporting them and not pressuring them. But what we also found too is that the fear tactics, yeah, we found that they don't work with our old women, but within the Bull program, young women's program that runs out of Yuma, those deadly little fear tactics that actually educates our young kids, and they're going to their parents and, you know, saying stuff about, you know, what smoking does, and then planting that seed within them as well. So we found that really works within our youth and our in-schools program.
Yeah, I think one thing about the way we work in our model of care too, like we've got our programs that are wrapped across, so we've also got have like our mums and bubs program, so we've got our midwives and that wrap around the and the other thing is, I suppose, without that Indigenous smoking, it was pregnant women but also women of childbearing age. That we just highlight that too, because it is about providing that individual support. And I think one other thing is that, like, we see it a lot is client-driven approaches, but I challenge that because I like client-centered. I challenge it with client-driven for the fact that if they have informed choice, they can drive their own health journey, and you know, we just be alongside of that journey.
The tool and the resource we are. And so Mingan Gujaga, so that's mums and bubs group, so they would hold their antenatal classes and maternal classes in the Powell building too, and just to introduce to the building, get a sense of what it's about, and each of our different sites are purpose built as well, so each site that you go into will have a different feeling, so which is why we have a lot of cross groups running through our homes.
I'm just trying to think of what other stuff to include areas. We our health screening days, so we do a number of hamper days too, and that's the same like all of our programs. We would have our tobacco team go out on site, do all the
so brief interventions, K10 assessments as well, Baxter readings, smokelisers, we use them a lot as well. They're really good. I don't know if anyone ever saw Smokey Sue. Does anyone ever remember?
Smokey Susie.
Yeah. That's what I was picturing.
So she still sits in our container, and you know, when you know mob going out there, that everyone's asking, oh, what's this, and so you know, bring her out and show everyone what it's about, but like we try and keep it away from the kids so that mum doesn't feel really bad, because they do, you know, and it's all about that trauma-informed care, right? And it's all about, you know, the effects of colonisation, and so we don't want to give them added stresses to increase their smoking habits, right?
And I think also just like what Hayley's talked about is that decolonising practice, and when it comes to Aboriginal health, see Aboriginal people as experts in that field. That's us we do this every day. And I was looking at this diagram and I thought it makes perfect sense when you think of Aboriginal model of cares and ARCHES and how AMS work, and we fit within this as well. So you think of, I was trying to think of where we would fit within that, because we're community, we're family, we're along that journey with the individual. That's a whole nother level of strength that comes in the way we do business.
Makes sense.